not, even for me, it's not something that I chronically screen for all the time, but it's just a good reminder to just keep that in the back of your head. Okay, so physical exam. So in a primary headache, generally your physical and your neurological exam will be normal. In a complicated migraine, like we talked about, you can have focal neurological symptoms. Things like weakness, sensory changes, ataxia, your tension headache, you can have pain on palpation of kind of your posterior neck muscles, and your cluster headache is associated with the lacrimation on the lateral side of the headache, and then nasal congestion as well. And the secondary headaches, depending on what is on your differential, your physical exam will vary widely. So always do a thorough neurological exam of anyone that comes in with a headache. A neck eval for nuchal rigidity, hematomas. Try to do a fundoscopic exam. It's really, really hard in the smaller kids. I can't. There's some that you just can't do. You can't do. But if you have a super high suspicion, it's important to kind of go down that path because it can be a super important tool. Abnormal vital signs, look for fever, elevated blood pressure, bradycardia, increased ICP versus like infectious pathology. Other things like, spring is coming up, so look for pale, boggy mucosa when you're thinking of seasonal allergies. And it just seems like there's been a lot more kids coming in with allergy type symptoms off late just because the weather's been getting warmer. So you'll probably be seeing a lot more of that. And when you think of allergy and allergic headaches, look for their allergic shiners. So they'll have dark circles under their eyes. These will be kind of sniffly kids. Mom will just say they have a runny nose all the time. Although that's not the best because I think every parent says that. So yeah, I don't know, something to think about. And then facial pain, and just keep your sinuses in mind. I have to look this up every time, just about the age of the development of the sinuses. So just look it up. I just don't think anyone's going to remember. I think just looking it up every time is really just the best reinforcement. And certainly signs of a closed head injury, skull fracture, which I think we're all fairly really good at. So there's some pictures. I'm going to put some pictures up. Tell me what you guys think this is and what disease that would cause a headache.
Ashley's.
Okay.
Tubers.
Cool. Yeah, so you'll have these kind of hypopigmented lesions. Something to think about. What about this? Yeah, someone said that. Okay, so cafe au lait, so you're thinking neurofibromatosis. You guys can just look up quickly the diagnosis for it. So there's a certain number you need, and there's a certain millimeter width that it has to be. So if there's only one, it's probably not a huge deal, but if the kid has multiple all over the face, certainly ask about family history of, especially it can be neurofibromatosis type 1 is the autosomal dominant, so something to keep in mind. And the reason I really kind of look for neurofibromatosis is because oftentimes I feel like a lot of the pediatric patients that come in almost come to the ER as our primary care. So, if you're thinking neurofibromatosis, it's not unreasonable to, I think, refer them to ophtho for kind of follow-up and, other services that they may not necessarily follow up with until, if the disease progresses. What about this? Yeah, I totally can't hear you guys.
It's non-blanching purple.
So, meningococcemia, so it's a non-blanching mercuric rash, which I don't know if anyone here has seen, but I certainly haven't. You have. So, yeah.
Patient died shortly thereafter.
Yeah. Yeah. How do they present? Do they present with?
Walkie-talkie and then died on their side.
Yeah.
If you see that, they're going to die.
And that really is, if you see this, they're really kind of on the tail end of their disease. We see less of this because of the really good preventative care that we get here in the United States, so, and Canada. All right, so diagnostic imaging. So, you know, primary headaches, generally you don't need any imaging. Less than 1% of these yield significant findings. Secondary headaches, you know, there's always this MRI versus CT. There's some institutions that have a fast MRI sequence. There's no great literature about the fast MRI sequence, at least from what I looked up when I was doing this lecture. So there's no like absolute protocol for it, and it's for the most part used in the VP shunt, CP kids that come in with concern for hydrocephalus, and these are kids that come in super, super often that historically used to get lots of CTs. So they're used for that, but I don't think it's really great for if you're looking for anything else other than that, and it's also really good if you have another MRI or a CT to compare it to, because it really is a comparison for a lot of these kids. We don't have that, I know at county we don't, but we don't have that at downstate. I haven't had to, does anyone know? Yeah. Yeah, so, but it does exist, and you know, where trained we used to use this, so it certainly will be present in the potential places that you only work at after you leave residency. It's really great, it's like 10 minutes, they're in and out, and it's wonderful. And then generally headaches associated with space-occupying lesions, typically have focal deficits, and for the most part, and you know, I never say never for anything, and EEG is not routinely recommended in the ER, just to throw it out there. I think most of us already know this. So let's talk about kind of the imaging recommendations for primary headaches. Imaging not recommended for your migraine, especially with a family history. Anything that kind of strikes you as like a acute like a primary headache generally doesn't need any imaging. When MRI is available, it's great to rule out structural lesions, especially in migraines with neurological deficits. And these are all the weird migraines we talked about that they kind of also mention here. Also seizures with like kind of postictal stages, but for our practice here, we don't have access to an MRI, so this is probably less relevant, but it's something to think about if you have access to that. So for secondary headaches, imaging is recommended, and I think this is also case dependent. So an MRI is preferred for headaches with neurological signs or symptoms of increased ICP, hemorrhage, meningitis, encephalitis, brain abscess. Certainly brain abscess MRI is the best. But I know for a lot of these, at most institutions where you don't have MRIs readily available, you would start with a CT. So you would start with a CT without IV contrast for a sudden severe, like a thunderclap headache. If you're looking for a bleed, CT is great. Remember, if your suspicion is really high and your CT is negative, it doesn't mean they don't have a bleed. Just something to always think about. Exclusion of impending herniation, subdural empyema, sinusitis, mastitis, trauma, and like I said, cases where MRI is not available. CT angio, an subarachnoid, an infarct, a dissection aneurysm, and then MR angio, but really I think we do that less commonly. Okay, so labs. So honestly, there's no routine labs that you would get for most headaches. It really is case dependent. For primary headache, there should be no reason you should be getting labs unless there are focal neurological symptoms that would make you concerned. Lumbar puncture you would do for things like meningitis, headache in the immunocompromised patient, low pressure headaches or like pseudotumor. And you can get, there's other labs that you can get depending on the presentation. And then treatment, which is I think the most important really for us. Like I think imaging and treatment are the two things that are really important for me. Abortive analgesics, use them as early as possible if you're thinking of primary headache. Avoid opioids and benzos. They have no role in a primary headache. And in secondary headaches, they're really case dependent. Make sure you hydrate them and use antiemetics. So for migraines, you want to give them fluids, Toradol, Reglan or Compazine, Benadryl, and this is actually shown to shorten length of stay, pain scores, and rate of admission. You can use dopamine receptor antagonists like chlorpromazine, I can't even say that, but Reglan, and it's just important to remind the side effects that can include QT prolongation, dystonia, akathisia, all the dopamine stuff. But this one thing that was really great was intranasal sumatriptan. I found out was FDA approved as an acute migraine treatment for children. I forgot to check when I was on my shift yesterday if we have that. I don't think we do because I haven't used it here. But if you guys have it, the stuff that I read is that it's actually pretty great. And it is FDA approved for acute migraine treatment. So if you can use it, it's really quick and it's great. So intranasal Imitrex is awesome. And then cluster headaches are going to be sumatriptan, oxygen can provide acute relief. Tension headaches, most are mild, self-limited. Like we said, a lot of these don't necessarily present to your ER, but you can do NSAIDs and Tylenol. The adult literature says there's potentially some role for TCAs, but there's no studies in children. I'm not sure if you guys use this for tension headaches in adults, but this is just what I saw already. All right, so dispositions. Indications for referral. So any chronic recurrent headache, sent to neuro, they kind of need some sort of, more for education, I think, and for kind of follow-up management. Complex headache pattern, failure responsive therapy, I think you want neuro on board. And certainly if you have signs of depression or anxiety, get psych involved. And then admission criteria, headache requiring continuous IV meds, chronic daily headache that's failing outpatient therapy, status micronosis, and then if you have a headache that you're really not sure where it's coming from, you're not able to figure out where it's coming from, you're not able to treat it, or worsening headache and anything with kind of focal neurological symptoms, certainly I think is a criteria for admission. All right, so let's do some questions. We're going to start off really easy. Okay, so 7-year-old boy presents with a headache and ataxia. To rule out a space-occupying lesion, which is the best imaging modality. Sorry. C. All right, we'll get the next one. All right, so 16-year-old girl with a history of migraines presents with a headache. She reports that it feels like every other migraine she's had in the past. What other further workup is indicated in the ER? Yeah, absolutely. So primary headaches, chronic, non-progressive, you don't do anything for. You give them abortive treatment and you treat them for that, but no other imaging or labs necessary, unless they're having focal neurological symptoms. Okay, so which of the following medications has best evidence for treatment of pediatric migraines? NSAIDs. This is the medication that we most commonly use in the ER for most headaches, right? All your headache kids get NSAIDs. And remember we said opioids have really very, if none, no role in primary headache treatment, and in secondary headaches it really is case dependent. And triptans are great, but NSAIDs are always going to be kind of your first. And intranasal sumatriptan for migraines, just keep that in mind. I think it's really cool. If you go somewhere else that has it, use it. All right, so frequent use of which of the following medications can lead to a medication overuse headache? Yep, all of the above. So really, most of these medications can, chronic use. And chronic use, more than 15 days a month. So 15 numbers, something to remember. All right, so let's do a couple of more wordy questions. Does anyone want to read them out loud, or do you guys just kind of want to read them? All right, I'll read them out loud. So this is a 16-year-old boy who has a constant daily headache for 1 month. Headache is all over his head. It's worse with coughing, sneezing, and laughing. He has mild nausea, photophobia, and ringing in his ears. He reports that his vision grays out sometimes, but he doesn't have tunnel vision or visual loss. He has a past medical history of acne, he's asthma, and ADHD. His meds include isotretinoin, montelukast, Flovent, and atomoxetine for ADHD. And he's also taking some vitamin B12 supplements and riboflavin. He has no family history of migraines. Those are his vitals, and his fundoscopic exam is shown. And this is a magical ER where an MRI was done very quickly and was normal. So let's talk about, anyone want to throw out some differentials?
What's elevated ICP?
Absolutely. Okay, so
Vitamin A.
Vitamin A toxicity.
It's not but still, what is it?
Isotretinoin on the outside.
yeah, no, absolutely. What would you do next?
Good LPN.
You would help me. Perfect. Perfect. So a lumbar puncture is done, and they describe the LP as
Middle. 34. You get to see that.
huh?
It's the opening pressure.
Yeah, that's I think that's kind of high. Yeah, it's super high. So I know someone had mentioned it, but what do you guys think is the cause of the voice symptoms? Yep, absolutely. So yeah, isotretinoin. So something to keep in mind, a lot of our patients don't necessarily know all the medications they're on. A lot of times you'll get a history of, I'm on a pill that I take for my acne, which could mean anything, but it's just important to keep in mind that it could be isotretinoin in the setting of a headache. Okay, so pseudotumor cerebri. So risk factors are weight gain, obesity, common medications such as isotretinoin, tetracyclines. The initial diagnostic eval is neuroimaging followed by LP, which we did here. So awesome. Okay, so next question. So this is a 10-year-old boy noted to be staring out the window at school. The teacher was unable to get him to stop staring or respond. He was brought to the ED. No other children were having similar symptoms at school. His vital signs were within normal limits for age. He's awake but seems restless. He follows one-step commands, so he's able to follow when you say take off your shoes, but is not able to follow two-step commands. He knows his name but not where he is, and the rest of his physical exam is unremarkable. What would you do next? Or let's talk about differential and then kind of what you would do based on your differential. So what's on your differential?
Infection.
Sure.
Confusional migraine.
Absolutely. Confusional migraine for sure.
Hypoglycemia.
Uh-huh.
Intoxication.
Yeah. Maybe took a shot before he went to school.
Acute psychotic.
Yeah. Anything else?
Sadness.
Maybe he's depressed.
Yeah, absolutely. Maybe he's depressed.
Seizure disorder.
Seizures, absolutely, right? Staring episode, not responsive. Definitely seizure, something to think about. So what would you guys, so we threw out like a bunch of differentials. What would you guys do next? So his vitals are normal, appropriate for age. Finger stick, normal.
Contacting parents or
Perfect, yeah. Okay. Any labs?
All of them.
All of them. Okay. Any imaging? What would you guys do?
actually dry ICT.
Okay. All right. So, and then I do talks also. As someone had mentioned, I think I should have talks. So, CT head without contrast was normal. Essentially, all your labs are unremarkable. And as you're completing your exam, the boys' patients kind of run in and they say, you know what, I don't think he's ingested anything. There's nothing that they know of that he could ingest at home. He has no history of seizures or headaches, no similar prior events. He is adopted, he has no known family history, and after about 2 hours of observations, he's alert, responding normally to commands. He complains of a headache and vomits. What is the most likely diagnosis?
Could be like a post-ictal period, and now he's having a post-seizure headache.
Yeah, no, absolutely. Anything else?
Confusion migraine.
Yeah, and that's the answer. So this is actually one of our pediatric board questions. So, you know, I kind of had the same reaction that a lot of you guys did. I thought it's not unreasonable that it can't be the other things. I think it certainly could be a post-ictal state. We certainly have had kids in a post-ictal state that have woken up, complained of a headache, and thrown up. But the answer to this is confusional migraine. But I think you guys are absolutely right. The fact that you're saying it definitely can't just be this, it could